Hello, my name is Jean Connor. I am a nurse scientist and director of nursing research for cardiovascular and critical care at Boston Children's Hospital. I would like to welcome all of you to our Nursing World Shared Practice. I am joined by Dr. Judith Vessey. Judy is a nurse scientist at Boston Children's Hospital in Medicine Patient Services and is the inaugural holder of the Leila Holden Carroll Chair in Nursing in the William F. Connell School of Nursing at Boston College. Dr. Vessey is a developmental pediatric nurse practitioner and a leading nurse researcher in the field of developmental pediatrics with a specialty in school health. And so with that, I welcome Dr. Judith Vessey.
Thank you so much for that lovely introduction.
And so this topic today of youth bullying, I think, is so important to our field. And for all of us to begin to understand youth bullying and how we could educate ourselves and actually intervene as nurses, I thought that maybe we could first just please describe what is youth bullying.
Sure. Youth bullying has been around really since the medieval time. I mean, they're the first recorded records. But it really has only been in the last 20 years that it's taken on a much broader life in public consciousness. And one of the watershed events, unfortunately, happened in the United States, and that was the school massacre in Columbine High School in Littleton, Colorado. And after that, a lot more people, lay public, legislatures and whatnot, began paying attention to bullying that happens in the schoolyard and in the community, and then also what it means for families. So it's really only been in the last 2 decades that there's been a swell of research and information that has come out on it, and that really is internationally based. It should be noted that the first work in bullying really began in Scandinavia, and then has moved across the globe.
I was fascinated by your recent publication, really describing the state of the science of what we know and what we should do as nurses, this call to action. And what caught my attention right away, I think in the first few sentences, was the percent of what we know of how often it happens. Was that surprising to you?
You know, it was, and I'll tell you why it was surprising. It was surprising on a couple of levels. First off, since I wrote that, the figures that have come out for the U.S. Centers for Disease Control push that up to 20 to 28%.
Okay.
That's a public health crisis. And yet the health community has not really paid very much attention to addressing that. So that was one of the, probably the biggest surprise for me, was not only the numbers, but sort of the lack of response. And I also was surprised that internationally, that the prevalence remains pretty much standard. I mean, there's difference by measurement techniques or whatnot, but whether you're a child in Japan, whether you're a child in Australia or England or France or in some of the African countries, those numbers hold.
At 20%.
20 to 30%.
So globally.
Globally, it's a global
That's
issue.
Interesting. Now, how do we define it? What is it exactly?
I think that's an incredibly important question. So when you really look at bullying, and I also just want, for our international audience, include the word mobbing, because that is
mobbing,
an equivalent word that's often used, particularly in the British Isles.
Okay.
But bullying really can be defined as those repetitive, persistent patterns of conduct by one or more children that deliberately inflict physical, verbal, or emotional abuse on another child, and where a power differential is in place. Now, what's really important about that definition is all 3 components need to be there. First, it's got to be a repetitive pattern. There has to be intent on the part of the instigator. And thirdly, there has to be a power differential. Now, Jean, you and I are a little older, so when we think about power differential in the schoolyard, we tended to think of the bully as the big kid, usually a boy, who would pummel other kids into submission.
So more of a direct
direct bullying.
Right.
Now, the power differential has shifted dramatically.
In what
so
way?
Much bullying now is done by, is cyberbullying.
So cyber,
by text messaging, sexting, setting up fake websites, there's a level of social toxicity that pervades the media that youth engages in on a day-to-day basis.
So there are types. So
they're
a
different.
direct physical,
Yes,
cyberbullying.
and then there's their indirect type. And indirect is more often occurs between girls. It's like in the cafeteria or whatnot, the gossiping and the whispering, or excluding one girl, or making fun of what she's wearing. So she knows she's on the outside but doesn't know exactly why. So we have all three of those. What is interesting is, and at first this is going to sound a little counterintuitive, but youth who are directly bullied in some ways are a little lower at risk. And the reason is everybody sees it happening. So interventions can come to that child more quickly. It's also easier for a student to get out of that environment, because if it's always happening on the school bus, you find other options.
Right.
For those children who are cyberbullied, though, it is often 24/7.
You can't escape.
You can't escape it.
Right.
And it's very private, particularly because parents are not as sophisticated in using technology as their children.
So we have a definition. We know there are different types, but who is involved in the bullying?
So the bully is the instigator.
Okay.
And the victim or recipient is the target for the bully. Now, there's a group of kids who end up serving in both roles, and we call them victim bullies. These are children who may not know social boundaries very appropriately, who tend to get in other children's space, or they tend to get their peers into trouble. So other youths will turn around and bully them because their behavior is inappropriate. And they may be more impulsive or more hyperactive. There's one group of kids that's particularly at risk for that, and I use those words cautiously, because a lot of youths are at risk for bullying in a lot of ways, but it doesn't necessarily mean they'll be bullied. But children who are diagnosed with attention deficit hyperactivity disorder of the impulsive hyperactive type are more likely to engage in behaviors that can really put them at risk for being bullied. Now, the other two groups I want to briefly mention are bystanders and a new term that we've labeled upstanders. We know that bullies like an audience. Now,
really?
Yes, because
it
enhances their perceived power when other folks are cheering them on for the behavior they're engaged in. Now, what you're going to say is, what's the audience for cyberbullying?
Well, that's my next question. Yes.
So, cyberbullying is very easy. You hit the send button to all your friends.
Okay.
So if you take a picture of another child in a compromising position, say in the bathroom, or all you have to do is send it out to send all. And then all of your friends also have seen the same picture and are making fun of the individual who may not even know what has happened. So one of our tasks in intervention is change bystanders to upstanders.
Upstanders.
And upstanders then are those youths who say this is not all right in one form or another. They can immediately seek help from a teacher or a responsible adult or a school resource officer. A parent, they can just tell the bully outright, just stop it. And if a lot of people are yelling, stop it, the bully isn't getting the reinforcement they want. Upstanders often work, though, in very different, quiet ways. So a lot of times the cues will come from friends of the victim to their parent or to the victim's parent, either one. So adults need to be talking to each other.
So again,
and
stay engaged.
Stay engaged.
Right?
Exactly.
Yeah. What are the things that we should be aware that what bullying could cause in the individual?
I think this is critical. We tend to think about bullying as causing short-term psychological effects. We now know that it's much, much broader than that. Some of the short-term effects that it can cause are anxiety, depression. We know youths who are bullied will have greater absenteeism in school, which can lead to worsening academic performance. Youth will choose to not engage in activities that were really important to them before. They will have, in schools, we see greater attendance in the school nurse's health room because they're trying to miss classes, they're trying to miss bullying.
Avoid.
Yeah, so all kinds of avoidance, loss of possessions. Interestingly, there's some new research just emerging that when they have looked at youths who have been bullied, they're also finding greater numbers of real physical illness. And there's been some very early work now on the immune system that shows long-term bullying can actually look at some depression in the immune system. And these kids are coming up with more otitis media, more sore throats, more upper respiratory infections, and so forth.
And would show up in our healthcare settings,
Absolutely.
our offices, and so
Absolutely.
working up the diagnosis, right? We need to think of this. I was very fascinated by that linkage.
These kids have elevated inflammation clear across. So that's huge if you think about what that means. Now my work began, and the way I got into this was working with children with chronic conditions. And they're children with chronic illnesses, developmental delays, and mental health problems, because they're youths who tend to be more at risk for being targeted. So I got into the...
Because of their illness.
Because of their illness.
It makes them different?
Yep.
I mean,
yep.
okay.
A lot of times they're smaller.
Okay.
They have more absenteeism. They may have health behaviors, condition management behavior that sets them apart from other youths in the class. If they're diabetics and they're having to test their blood sugar,
Right.
That's at risk. There's been a big campaign in the United States called Just Say No to Drugs, referring to illegal substances. But if you're a child with a chronic condition and you've got to, say, take cystic fibrosis, for example, and you have to take a number of pills before every meal, then that sets you up for greater risk. So that is another whole reason for that. So any behavior, and this is another really important concept, whatever sets a child apart from his peer group puts him or her at greater risk. And then lastly, if they're really different than whatever the norm of their community is. So if a child is in a school where the value is not to do well and most of the other students don't perceive that they're going to go on to college, that child's going to be more likely to be targeted, and vice versa. It's just whatever makes them different. So race, ethnicity, goal, drive, how you look, anything along this spectrum.
At this time, we would like to engage all of you. When providing your response, please put your city and country first. In your current practice, do you routinely screen for youth bullying? Please describe. So I was thinking about this whole idea of teasing and what's normal, what's not normal.
That's a great
And I just
question.
thought we should think about that when thinking about measurement, right?
Yep, and that is a great question. And actually, the way I got into all this work was through teasing.
Is that
because
right?
I began working in this area prior to the Columbine High School shootings, and really began looking at teasing as a proxy measure for how children with chronic conditions do in schools. And when we started, there was very little literature, very little research on that. But what made it fascinating when we began parsing out the concept was there's good teasing and there's bad teasing. And if you think about it as two perpendicular lines, with the recipient on one and the instigator on the other, I want you to think about your friends when either now or when you were a child. And our friends would give us messages through teasing that were helpful. So we know kids will give messages to each other about what isn't appropriate behavior. Adolescents will send sexual signals to each other, which is developmentally appropriate, even though their parents might want them not to do that. And all that kind of stuff. So when the message is sent to be helpful and you receive it that way, that's positive teasing, even if it's got a little bit of an edge.
Yes.
On the flip side, if I intend to harm you, and I deliberately seek and repetitively go after you, and you receive that, which is clear that that's
in that
bullying.
harmful way.
In a harmful way.
Okay.
That's clearly bullying. The other two quadrants for me are more interesting. What we really need to do is work on making all of our patients and all of our youth just much more resilient in handling what life throws at them. The upper quadrant, which is the last one, and this is where a lot of my work is focusing now, is these are teasing them, but maybe in a kind of a nasty way.
Yes.
But the youth has perceived it as bullying.
It's almost like a lower threshold,
A lower
right?
threshold.
Yeah.
And it starts this downward spiral then of what might have been maybe some nasty teasing to frank bullying. So our responsibility as healthcare providers is to really try to prevent any of that, but then intervene all the way along. But I think why this is such an important topic is we now know that youths who have been bullied carry that into adulthood. We know that they have lower thresholds and a worsening quality of life all throughout life than youths who have not been bullied over a sustained period of time.
And are they more at risk for bullying? So
They may
they've been
very well
bullied,
be.
and then do they repeat that behavior?
They
Is
can
that
do one or
something-
two things. They can
Okay.
be victimized throughout their whole lives, or if they get into a position where they have
Change a role?
and
Yeah.
power, then they can become bullies.
Okay. I'm thinking about all of these different things, and then as a scientist thinking, well, how would we measure it?
In some ways, bullying's a bit like pain.
Pain,
If I say
yes.
I'm in pain, you
Right.
need to believe I'm in pain.
Right.
If you tell me you're bullied, I need to believe that. But I need to believe it within the definition of what is and what isn't bullying. If you're telling me you're bullied, and I can see by the environment that that's not really the case, my job is to help you reframe that. And what makes this difficult, though, is using a uniform definition. And the other thing is because peer relationships in young people are so fluid, where it really may be bullying one day, a week later that
So a very dynamic.
very dynamic.
Okay.
That child may be completely accepted into that group.
What are the ways that you've traditionally captured this information?
So my original work, I really wanted to go right to intervention and look at how we could begin working with identifying and immediately intervening with specifically children with chronic conditions who were being bullied. And I went out to the literature, and when I was started, there was no measurement tool
As the scientist.
whatsoever. So, and so it was really clear we had to go back and start with measurement. So I was fortunate enough to receive funding from the National Institutes of Nursing to develop a measure which we call the CATS, the Child Adolescent Teasing Scale.
Yes.
And since we started that work, the concepts of teasing and bullying have become more fully explicated, so it is a very good crossover measure. But what we did first was we interviewed, conducted focus groups of middle school youth, and these are kids between the ages of 11 and 14 from around the country. So we did it geographically to catch different populations. So we went to inner cities, metropolitan areas, rural areas. We went to the south, the northeast.
So very inclusive.
We went New Mexico, Montana. We wanted to capture the Hispanic population. We wanted to capture American
cultures,
Indians,
yep.
African Americans, rich, poor, in between.
So the whole story.
The whole story. Took all that together and then came up with a list of items which kids were teased or bullied about. And then we worked very hard to simplify those items so they would be at like a 4th grade reading level.
Okay.
So unlike most tools. So they're like one word. So it's like I'm teased about my body, my stuff, my parents.
I love the simplicity of it. That's what I really appreciated.
And so it makes it really
It
pretty
does,
usable.
yeah.
And then the other column was how much does it bother me? So we did that. We put all the items together, started with 70 items, used classical test theory and factor analysis for item reduction, and came down with 32 items. And that instrument has really stood the test of time, and we've been really fortunate, and it's been translated into Mandarin, Portuguese, and Spanish with all validated versions. And they're the ones that I know of. But the problem with the instrument is, and as a scientist, you know, you're always looking at what the next step is.
Right.
It's still not terribly flexible for clinical use. So
work to be done.
Our next step was we've just completed a systematic analysis of all of the instruments that have been published, where there's been psychometric studies published on them, specifically to teasing and bullying. And we did that to really look if there's anything out there. So there isn't. So the work we're engaging in now is to develop a brief screen that can be used in primary care with
in the clinical setting.
In the clinical setting, that nurses, physicians, and other healthcare providers wrap our arms around this problem and own it, to pick up kids early on. Now, the model that I've used for this work is the public health prevention model. We have primary prevention, secondary prevention, and tertiary prevention. And for those in the audience who may not be completely familiar with this, I'll give you just a brief introduction. But primary prevention are those activities that one engages in to keep the problem from ever occurring. Secondary prevention really focuses on how early can we detect the problem, although the symptomatology may not be, terribly evident. And tertiary prevention is when the problem is clearly symptomatic and there's a lot of issues. The example I always give is cardiac disease, and you'll just have to bear with me because I'm not an expert on this. But in primary prevention, what we really work on is helping kids develop exercise patterns, healthy eating, healthy weight, learning to manage stress early on. Secondary prevention, though, and we're doing this more and more, is we're screening for cholesterol in kids, for kids who have lipid profiles that are not what we would anticipate, and then begin intervening at that level. We are, hypertension, again, if they have, begin actually treating that earlier on, because we know that these are risk factors for cardiac disease. If we don't handle that now, then adulthood, what we'll see is those individuals that might have myocardial infarctions or other major heart disease.
Very real, right.
And after that incident, you can get better, but in some ways it's always palliative. You will never get a heart that looks as good as the heart of an adolescent.
Right.
So I want you to switch that in your head to bullying. So in primary prevention for bullying, we have an enormous amount of energy being put in most certainly in the US and elsewhere in the world, in programs in school to stop bullying. And they may improve the climate, they may use more empathetic. However, the long-term studies of those have really shown that they're not terribly effective. We know from any type of health education, you got to repeatedly give the message. But with any child and behavior, it's what they see, it's not just what they hear. So it's behavior. So if they go home and everybody's bullying in their families, then that's not the behavior that they see that they can hold up as how they want to be. But the other thing is, schools are usually are only responsible for the behavior of their students in school and maybe getting to and from school.
Right.
With cyberbullying, which is 24/7, a lot of the bullying takes place off the school ground, outside of the school day, and schools may have very little authority to address that.
Right. Okay.
So
today,
that's why I think it comes back to healthcare providers.
Right.
We need to
a real opportunity.
It's a huge opportunity for a couple of reasons. First and foremost, we seek to deliver patient and family-centered care.
Yes, that rung so strong in this story, I thought.
So that's the beginning. And then the other part of me, because I do have a degree in business, is we don't want to be spending our health care resources badly. So if the real problem is bullying, how many dollars do we want to spend on a physiologic workup or assessment for a condition that really isn't the root cause? Now, some of that you do that for ruling out other conditions and whatnot. But if you never ask about bullying, you might have missed missed the
sole cause of what the physical.
Exactly. So you have to get to the antecedents.
At this time, we would like to engage all of you. When providing your response, please put your city and country first. Do you have any policy guiding measures and prevention at the level of your country, your practice organization, or in your clinical role? If yes, please describe. I love your framework of the different levels of prevention. So what is it that we should do? We think this is a world shared practice.
Well,
what could we do?
I don't think we want to wait until the perfect screening tool comes out. Hopefully we'll get there. But I think every time we interface with a child and their family, and particularly in the, say from age 8, 9 up through 16, that tends to be the highest risk group, we just need to ask them,
So it should be part of that
assessment,
intake assessment.
So, and also remember, if you got 20 to 28% of kids who are bullied, somebody's got to be bullying them. And where parents who feel really left out of the process is, they may fear that their child is a bully, but they can't ask the school because the school may have policies around suspension and whatnot that they wouldn't want to set up a concern that their child is the bully for fear of the ramifications for them. Healthcare, we can do that. Because in healthcare, what we can do is if a parent is worried that their child is a bully or being bullied, we can get them the resources they need. We can refer them to mental health. We can give them some online
So we're the
strategies.
Safety net.
We're the safety net.
What would be the question you would ask? How would you ask it?
I would ask parents and youth separately, because a lot of times a child will not say in front of their parents that are bullied.
So do separate.
So I would do separate.
Okay.
One question you could ask in general is, we've been hearing a lot about bullying. Is there any bullying in your school? Are you involved? What's your school do about it? And engage at every visit. So
at every visit. So this is important.
And the other thing we do is we often forget to ask the second question. So you're working in the emergency department, and in walks this young woman with a questionable fracture of her arm, and you say, "Oh, how'd that happen?" "Oh, I was running." "Oh, well, you should watch where you're running." Wrong answer. Why were you running? That's the next question.
Okay.
That's why I talk about asking the second question, because was she running from someone? Was she being scared? Had she been egged on to doing something that she knew she shouldn't be doing as a threat?
Is the second question still to the child, or when do you bring the parent in? Because we've talked about partnership with families.
As we know in clinical care, every family is different. So with some families, it's probably okay for both to be there. But at the end of the second question, and to, let the child know that I'm really here to help you. Is it okay if we talk with your mom and dad about this as well? And see where that goes.
So a safe place.
A safe place. Now, you always have to keep in the back of your mind, some children fear the response of their parents, because if they happen to be living in a family where the one parent is particularly aggressive, they may be really afraid that that parent is going to make it worse for them by approaching the bully's parents and really fueling the situation. So all of that really needs to be done on an individual basis, and it's why it's so important that we really know our families. So take your cues from the child. If not that visit, when you bring them back, follow up. And if it's an older child, give them your telephone number.
Right.
Or suggest to them, do you feel comfortable seeing your school counselor? Some will say yes, they hadn't thought about it. Or your school nurse. School nurses, the school nurse health room has been rated by youth as one of the safest places in the school building.
Good to know. So again, nursing,
so
right?
Nursing. So, but not, so with all of those, it's who the child feels most comfortable with.
At this time, we would like to engage all of you. When providing your response, please put your city and country first. Do you have a referral guideline for a youth that you have identified as being bullied? If yes, please describe. And then as we think as nurses, so our nursing organizations, our leadership there, what should we be thinking? What should we be looking for?
This is huge.
Kind of resources, support, voice.
I'm so glad you brought that up. This is absolutely huge. We actually looked at this, and of all the nursing organizations, we only found 3 with any type of position or white paper on bullying. And as you would expect—
Were you surprised?
I was shocked.
You were.
Because it wasn't even all the pediatric nursing organizations didn't have papers. So, for example, any organization where we know their membership is caring for youths at risk should be informing their members on some level. So for example, the organizations where they have a large number of cosmetic and plastic surgery nurses, they really need to know about this issue because of a lot of their clientele. But I would go back to children who have oncologic conditions or cardiac conditions. We know that they're high-risk groups.
Right.
Oncology is very interesting. Social marketing has done such a wonderful job in making children undergoing active chemotherapy with hair loss want to feel accepted. But the problem is after they're off of therapy and they go back to school and they may have some low-level learning disabilities or other kinds of things, that's when they're targeted. So I think we all just need to look at where we are in the nursing world and think, how can we begin making a difference at very different levels?
On the front lines, and then in our other leadership scope opportunities to really understand not only what it is, but what our role is in preventing.
Absolutely. So whatever, and I go back to my roots specifically in caring for kids with chronic conditions, and just on whatever avenue we interface with these children and their families, is to take this as an avenue to also just see how they're doing, their mental and emotional health around school.
So I'd like to just see if there are any last thoughts, and then thank you for this wonderful time of just really telling us something that is so important to all of us on so many levels. So
I just wanted to thank you so much for this opportunity. You don't often get this opportunity, and just to let everyone know that you can do the smallest thing to make a real change in a child's life, and just to take home some little piece of this message, and wherever you engage with children and families, to think about including some of these sorts of messages and really help with the prevention of this horrible, horrible, pernicious condition.
So again, Dr. Vessey, thank you for your
thank you
expertise.
so much. It's been delightful.
Thank you.